Today I will talk about the paper Endoscopy-assisted resection of a sphenoid-wing meningioma using a 3D printed patient-specific pointer in a dog. This is from November 2022 from Frontiers in Veterinary Science. Let's get started.
Endoscopy-assisted resection of a sphenoid-wing meningioma using a 3D printed patient-specific pointer in a dog. A case report. Abstract. A 9-year-old female mixed breed dog presented for treatment of a presumed sphenoid-wing meningioma. Clinical signs included tonic-clonic seizures lasting 1 minute, which had started 3 months previously. The physical examination results were unremarkable. An eccentrically located neoplastic cystic structure in the right sphenoid bone region suggestive of a meningioma and paratumoral brain edema was observed in preoperative magnetic resonance imaging. Prior to surgery, a 3-dimensional patient-specific pointer was designed using computed tomography images and computer-aided 3D design software. After a targeted approach and exposure of the lateral part of the right temporal lobe via craniectomy guided by the 3D PSP, complete macroscopic piecemeal resection of the meningioma could be performed using endoscopy-assisted brain surgery. Post-operative MRI confirmed complete excision of the tumor. Anticonvulsive therapy was discontinued after 90 days, and the dosage of anticonvulsants was tapered 2 weeks after surgery. At a follow-up examination 225 days post-operatively, recurrence of seizures was not observed, and the absence of tumor recurrence was confirmed by a repeat MRI examination. To the best of our knowledge, this is the first report in veterinary medicine describing a successful resection of a sphenoid-wing meningioma using a 3D PSP-assisted craniectomy may be a surgical option for some canine skull-based tumors, such as sphenoid-wing meningiomas. Introduction meningiomas are the commonest primary intracranial canine tumors, especially in large breed dogs, representing 49 to 51.5% of all intracranial neoplasms. Meningiomas can occur at many sites, including the olfactory frontal region, the skull base cavity, and the suprasellar and parasellar regions. However, skull-based meningiomas are rare in dogs and cats, and the prognosis of these tumors depends on several factors such as location and therapeutic strategy. Most meningiomas in humans are treated with complete surgical resection, and the recurring tumors are treated with chemotherapy and/or radiotherapy. However, preoperative brain biopsies and complete perioperative surgical removal of tumors are challenging, and few reports describe their use in veterinary medicine. Preoperative surgical planning and accurate perioperative surgical techniques are essential to achieve good functional results. However, surgery of the canine skull base is challenging because of the complexity of the vessels and nerves in this region. Determination of the safest and most accurate approach is essential to minimize permanent surgical trauma to the normal brain. Neuronavigation and the endoscopic approach have been developed to increase the accuracy and safety of surgeries. However, NN has several limitations when applied to canines. NN can interfere with the surgical approach due to the relatively small size of the canine skull. Cost also plays a key role in limiting its adoption in veterinary medicine. Recently, 3-dimensional printing has been widely used to overcome these limitations in neurosurgery. 3D printed patient-specific skull contoured brain biopsy guides have reportedly aided needle placement into the target in dogs. 3D patient-specific drill guides have also been reported to be widely used for accurate spinal screw placement. Very few reports of veterinary skull-based meningiomas seem to exist. Moreover, unlike human medicine, no specific surgical strategies are available for individual tumor sites in dogs. Here, we describe the feasibility of targeting sphenoid-wing meningiomas using a fabricated 3D printed patient-specific pointer and the endoscopy-assisted surgical procedure that overcomes the limitation of a complex and challenging surgical site. Case description: Case a 9-year-old female mixed breed dog with a body weight of 15.1 kg and a body condition score of 5/9 was referred for generalized seizures and meningioma. The reported clinical signs included tonic-clonic seizures lasting 1 minute, which had started 3 months prior to presentation, and decreased appetite. Hematological and blood investigation results were within normal limits except for the liver panel findings. The levels of alanine transaminase, alkaline phosphatase, and gamma glutamyl transferase levels were mildly elevated. At presentation, the physical and neurological examinations were normal. The computed tomography and magnetic resonance imaging examinations performed at the referring veterinary clinic had discovered a large eccentrically located cystic structure under the right sphenoid wing. The marked uniform contrast enhancement of the heterogeneous cystic remainder was confirmed on CT and MRI. In addition, contrast enhancement revealed well-defined, broad-based tumor margins conforming to the meningeal plane. This structure showed heterogeneous, intramural fluid accumulation, characterized by an enlarged, sharply defined outer margin with a significant hyperintense signal and paratumoral edema on T2 weighted images. Based on the imaging characteristics, cystic meningioma was suspected. Neither thoracic radiography nor abdominal ultrasonography revealed any abnormalities. Choice of surgical technique: the lesion resulted in mass effect, intracerebral edema, and associated signs such as generalized seizures, which were indications for intervention in this case. CT was used to measure the extent of bony invasion or hyperostosis due to the possibility of the tumor infiltrating the skull bone. T2 weighted MRI imaging identified intraparenchymal edema and important structures such as the cavernous sinus and optic nerve. Schematic images were prepared for preoperative planning using CT and MRI, which demonstrated the approximate relationships among the tumor, cerebral arteries, optic nerve, and bony landmarks. The tumor was identified as sphenoid-wing meningioma of the skull base. A craniectomy with dura mater resection was planned. In human medicine, lateral and middle sphenoid-wing meningiomas can be resected using theriional craniotomy, but this is a challenging technique due to closely located neurovascular structures such as the optic nerve, the cavernous sinus, and the middle cerebral artery. The relationships between the vascular and bone morphology and the anatomic landmarks have been clarified in human medicine, but little information of this kind is Available to assist sphenoid-wing meningioma surgery in veterinary medicine. Dogs have relatively massive temporal muscles in different sizes, locations, and morphologies of neurovascular structures and structures such as the zygomatic arch and the coronoid process of the mandibular bone. Therefore, for accurate and safe delineation of the surgical site, we decided to employ a 3D printing technique similar to the use of a 3D printed biopsy guide, since we lacked NN capability insufficient experience with traditional in silico planning and in vivo measuring techniques. Planning and production of the 3D PSP surgical planning, including confirmation of the location, size, and shape of the 3D PSP and identification of the exact location of the tumor, was performed using computer-aided 3D design software applied to the MRI and CT images. This was necessary because a PSP used in brain surgery can differ in detail from patient-specific guides used on the spine. Detailed guide concepts and methods have been described previously. Post-contrast CT images of the patient were obtained in the DICOM file format and converted to stereolithography files. Segmentation, 3D model reconstruction, and prosthesis design were then performed using computer-aided design software. The design process required 1H. The tumor was confirmed in a sagittal cut of a 3D bone model using the computer software. A 3D tumor targeting cylinder passing through the sphenoid-wing bone was created, and the diameter and location of the cylinder were designed to match those of the tumor. The diameter of the resulting pointer was twice that of the cylinder. The footprint of the pointer represented the margins of the planned craniectomy and allowed sufficient surgical space for tumor resection. An attachment arm was created for the PSP, which was designed to fit the most characteristic surface of the frontal bone and sagittal crest. The surface of the arm had an inverted skull structure to ensure stable bone attachment. Once the arm was fixed, the pointer automatically indicated the craniectomy site under which the tumor was located. To ensure accurate surgical planning, rehearsal surgery was performed using a 3D printed bone model in the PSP. Both were printed using the RS6000 3D printer according to a previously described protocol. Printing and sterilization of the 3D bone models and the PSP prior to the real surgery required 1 day. Surgical technique midazolam and propofol were used to induce anesthesia. After intubation, oxygen and total intravenous anesthesia were used to maintain anesthesia prior to durotomy. The drugs used for total intravenous anesthesia were propofol, 0.05 to 0.5 mg per kilogram per minute, constant rate infusion, propofol registered, Myung Moon Farm, and remifentanil. Anesthesia was maintained with isoflurane post-durotomy. Plasma light was administered throughout the surgery. Prior to surgery, the dog received phenobarbital, prednisolone, dexamethasone, cefazolime, mirapitant, and mannitol. The surgical procedure was based on sphenoid-wing craniectomy. The fur was clipped from the lateral canthus of the eyes to the occipital protuberance, and laterally to the zygomatic arches. The skin was aseptically prepared with chlorhexidine and disinfected with alcohol and povidone iodine. The dog was placed in sternal recumbency with its head elevated to 30 degrees. A 6 cm vertical scalp incision was made dorsal to the zygomatic bone. The platysma was incised vertically. The superficial temporal nerve and rostral auricular nerve were retracted caudally, and the zygomatic branch of the facial nerve was retracted cranially. The zygomatic attachment of the temporal muscle was incised and bluntly elevated from the temporal bone. The scalp and temporal muscles were turned over and fixed laterally using a Sen-and-Gel-B retractor, and a wide spatula was used to maintain the surgical field. After separating the muscle per requirement, the pre-made 3D PSP was applied to the skull landmarks described in section planning and production of the 3D PSP without complete removal of the periosteum. After dissection of the soft tissue of the skull, the craniectomy site was determined based on the 3D PSP. The craniectomy line was made along the outer boundary of the pointer using a surgical pen and electrocautery. The bone was resected using a 2.0 mm bone burr along a tool path indicated by the 3D PSP, following which the tumor could be immediately identified. After exposing the tumor using the pointer, we maximized visualization of the surgical site using an endoscope. Under endoscopic visualization, durotomy was performed using a number 11 scalpel and micro scissors, and the ventrolateral aspect of the lateral temporal lobe was exposed under an enhanced surgical field. To magnify the surgical site, a 10 mm, 0 degrees rigid telescope was connected to a high-definition camera system. A mechanical endoscope holder was used to maintain the position of the endoscope. The tumor margins were then carefully dissected away from the normal brain tissue until macroscopic, piecemeal resection was complete. Although the location of neurovascular structures was not easily identified, there was no significant bleeding. Following tumor removal, we applied Flowzeel registered. After confirming complete hemostasis of minor bleeding, the craniectomy area was covered with temporal muscle. The incised temporal and masseter muscle, subcutaneous tissues, and skin were closed per set guidelines. A biopsy specimen was removed from the tumor and fixed in 10% neutral buffered formalin for histopathological examination. 18-day post-operative MRI confirmed that the tumor was totally removed. Outcomes, complication, and follow-up post-operatively, temperature, pulse, respiratory rate, capillary refill time, blood pressure, auscultation, and neurological status were monitored. Post-operative analgesia was provided with remifentanil while observing the patient's pain reaction for the first 12H. The analgesia was terminated the next day, and the patient was encouraged to walk. Hartmann solution was administered for 24 to 36H. The patient received cefazolime for the first post-operative week, and phenobarbital was tapered over 3 months post-operatively. The clinical features and the results of histopathological examination of the surgically resected tissue samples were suggestive of a grade 1 meningothelial meningioma. 32 days after surgery, the patient was readmitted to our clinic because of fluid fluctuations at the surgical site. The owner reported that the patient repetitively scratched the surgical site at home. Ultrasound was used to discriminate the fluid, and the presumptive diagnosis was seroma. The fluid was red, and analysis showed a hematocrit level of 4.5% and total nucleated cell count of 24,910 cells Greek letter MUL. The seroma responded well to surgical debridement and application of a Baravac drainage tube, which provided continuous negative pressure. The follow-up observations comprised repeated neurological and MRI examinations for 296 days post Surgery. Recurrence of seizures was not observed, and complete tumor resection with resolution of peritoneal brain edema was confirmed by repeated MRI. Discussion. This is the first case report describing a feasible, endoscopy and 3D PSP-assisted, sphenoid-wing meningioma resection in a canine patient. The PSP allowed us to perform the craniectomy targeting the brain tumor. Complete macroscopic piecemeal resection of the sphenoid-wing meningioma was performed accurately without injuring the main blood vessels. The patient had a good clinical outcome without significant complications over 296 days of follow-up. Sphenoid-wing meningiomas are a type of skull-based tumor. There are extremely limited reports of these tumors in dogs and cats. In humans, complete surgical resection is the recommended treatment. However, surgical treatment is an arduous task for several reasons. First, skull-based tumors are located deep under the brain. Thus, it is challenging to target the tumor accurately and perform surgical resection in a limited operative space. In addition, several arteries and veins are present in complex areas of the skull base, and the restricted field of approach makes it difficult for the surgeon to perform complete tumor resection without vessel injury. Neurosurgical planning is vital to determine a precise and safe surgical approach for minimizing brain damage in patients with skull-based tumors because of the closely located, critical neurovascular structures. Therefore, the surgeon must be familiar with vascular and bone morphology as well as with anatomy. Visual interpretation of conventional MRI scans is usually sufficient for diagnosis, but the planning and execution of neurosurgical procedures require transformation of these data into a 3D space. In humans, NN has improved the 3D localization of brain tumors. NN captures vital neurovascular structures as well as critical neighboring structural and functional regions, and converts this information into digitized neuro or radiological data. An optimized approach is determined through the simulated pre-surgical step, which can significantly facilitate skull-based surgeries. Furthermore, recent frameless NN systems have improved the usefulness of NN in skull-based tumor surgeries. In veterinary medicine, NN has reportedly allowed surgeons to approach the pituitary fossa with clinically acceptable accuracy. NN has also been used to obtain diagnostic brain biopsy samples. However, the relatively small size and thickness of the canine skull compared to humans makes it difficult for neurosurgeons to apply NN accurately in dogs. Attempting NN in the presence of a large volume of temporal muscle and zygomatic bone could result in longer access times and narrower surgical fields. These limitations make it difficult for veterinary neurosurgeons to apply NN to sphenoid-wing meningioma resection. However, 3D printed biopsy guides have been recently used for veterinary medicine without NN and have proven feasible in terms of outcomes. 3D printing technology offers significant advantages for neurosurgery. 3D printed material can facilitate pre-surgical planning by converting visual images into tactile models. Surgeons can rehearse realistic surgery because 3D printed materials can be milled, cut, and drilled with the usual surgical instruments as often as required. Customized prosthetics, implants, fixtures, and 3D printed biocompatible materials have been widely used recently. This 3D printing technique can have several advantages when applied to brain surgeries. 3D printed guide techniques such as 3D brain biopsy can designate the surgical location more accurate and less invasive. When resecting brain tumors, precise surgical site exposure is crucial to avoid excessive manipulation of the brain parenchyma. If the surgical window is inaccurately delineated at the first time, expansion of the surgical window size would be inevitable. Moreover, it can be applied to the hands of less experienced surgeons. Surgeons with 3D PSP can be preoperatively accustomed to patient-specific circumstances, such as neurovascular structures and anatomic bony landmark in the course of 3D planning. Also, surgeons would reduce the surgical time because they can skip the setting of the neuronavigation system and special imaging instruments perioperatively. In the present case, the exact craniectomy site could be easily and safely determined, avoiding in-surgery modification of the surgical window. The 3D printed implant fitted perfectly to the skull surface only at the predefined craniectomy site. Any slight displacement of the print would have led to an incongruency between the undersurface of the print and the surface of the skull, thereby indicating inaccurate positioning. The positioning of the 3D print was also limited by the narrow and deep approach to the sphenoid bone. However, in close-up positions, an endoscopy-assisted approach can provide a clear view of the surgical view. This advantage is beneficial during surgical procedures for deep-seated lesions in narrow spaces. Therefore, a 3D PSP combined with an endoscope can facilitate the complex procedure of sphenoid-wing meningioma resection in small breed dogs. In human medicine, the surgical management of sphenoid-wing meningioma is reportedly challenging because of the deep and narrow surgical site in the skull base and the proximity of critical neurovascular structures such as optic nerves and arteries. In this case, the surgical approach, surgical view, and space for instruments were insufficient due to the tension around the temporal muscle and the coronoid process of the mandibular bone. Gross total resection requires elevation of all the tumor-infiltrated tissues, including the dura mater, to avoid tumor recurrence. Here, after tumor resection, the craniectomy window was covered with the temporal muscle. The dura mater could not be repaired with artificial graft because the working space was insufficient. MRI showed cerebrospinal fluid leakage with evidence of a CSF fistula outside the right frontal lobe 18 days post-operatively, which significantly improved 225 days post-operatively. In humans, CSF leakage is reportedly a complication of cranial and spinal surgery, especially when the final structural repair of the dural defect is incomplete. Accordingly, it is reasonable to presume that the CSF leakage in our patient was caused by the dural defect. CSF leakage has been associated with secondary complications such as meningitis, encephalitis, and wound infection, and thus various treatment options have been established for persistent CSF leakage in humans, including conservative therapy, epidural blood patches, and surgical patches. However, reports describing treatments for CSF leakage in animals are rare. Our patient was treated conservatively, as several studies of humans have suggested conservative treatment for almost all CSF leaks. In our case, it remained unclear if the seroma observed after 32 days was associated with the initial CSF Leak. This study had some limitations. First, the duration of time required to design and print the 3D PSP models was relatively long. This represents a significant limitation on the use of this model in emergent situations, such as intracerebral hemorrhages. Second, the surgeon's technique has a major influence on accurate pointer positioning. To ensure a perfect fit, the surgeon must separate the soft tissue sufficiently for adequate exposure of the area where the pointer will be applied. Slight deviations of the pointer during surgery can have serious consequences such as introducing errors in the craniectomy site. Improvements in software and adequate surgeon experience would increase the effectiveness of 3D PSP applications. Third, we have included the findings of only one dog, although the feasibility of 3D PSP aided complete resection of sphenoid-wing meningioma has been demonstrated. Fourth, we could not evaluate the location or size of the surgical window, as previous studies have done, because post-operative CT was not performed. Although the 3D printed pointer can be modified to fit the patient, further research is necessary to compare the accuracy and utility of this method with current best practices. Further studies with larger samples of dogs are also warranted to simplify the pointer manufacturing process and ensure the accuracy, reproducibility, and reliability of this technique. The development of additional methods and techniques is required to avoid damage to critical vessels such as the middle cerebral artery during resection of skull-base tumors. In humans, brain angiography has been successfully applied prior to surgery to determine the meningioma's relationship to the surrounding vasculature and their degree of encasement. However, reports describing these tumors in veterinary medicine have been very few and application of angiography proved impossible in the present case due to the owner's financial constraints. Further studies on the use of MRI and CT-based brain angiography in veterinary medicine are warranted. Conclusions: we demonstrated that sphenoid-wing meningioma could be safely approached by endoscopy-assisted 3D PSP without requiring NN. Clear visualization resulted in complete resection of the skull base meningioma. The described method is a viable option for performing skull base craniectomy in dogs.
So just to summarize the study, they used a 3D guide to show the window for surgery. This is something that I do on almost all of my craniotomies. My design is different, but again, a similar method. And I do this other than emergency situations, such as with skull fractures. I find it very helpful, even with some of the routine procedures, such as a transfrontal craniotomy. These types of guides are really only helpful, however, in extraaxial tumors, or if they're intraaxial but on the surface. For intraaxial tumor removal, I feel guides are not as helpful. Something I will say about designing the guides is you do get a much better understanding of the surgical approach and what to expect in surgery. It also helps with getting a grasp of the anatomy and how the vasculature is associated with the procedure. So even if you are not going to use a guide, just doing the surgical planning with 3D software, I feel is invaluable. It's also extremely helpful for training residents and teaching students just to help them get a better grasp as to what's going on with surgery. Getting into the paper, the figures are fairly self-explanatory. One thing I will comment on is that they state the tumor is in the temporal lobe, but I feel at least in part the tumor is in the piriform lobe, but I don't have all the MR images to say for certain. In any case, a transzygomatic approach would have been another surgical option for this dog. This is not a common procedure, but one that I have done with success. The paper never discusses this as a surgical option, but I feel that it is at least worth stating. It is important to know, however, that you wouldn't be able to use a 3D guide with the transzygomatic approach. Again, just something I feel that the paper should have discussed. A couple of other things to comment on is the surgical design guide being only 1 hour. That I find is impressive given the design of the guide itself. I've never used the software discussed in this paper, but if it is that quick at making these designs, maybe I should look into it. Generally, I use MeshMixer because it's open source and fairly user-friendly for surgical guide planning. For more of the advanced models, I typically use SolidWorks. It also does not state what kind of material was used for the print, at least not that I found. The RS6000 printer is a resin printer, but there's dozens of types of resins which have different properties. So for us to replicate the design, we're not able to truly do that without that information, although I'm going to assume that it's some sort of surgical resin. I do agree, however, that from planning to printing to post-processing generally takes a day for a surgical guide. I'm curious why the dog was placed at a 30-degree angle. Was it because it was easier or just because of the thought with people that this decreases intracranial pressure and could be helpful during the procedure using gravity to help pull the brain a little bit from the calvarium? Placing a patient at an angle is not something that I typically do, and I was just curious why they did it in this paper. Though the paper focuses on the 3D guide, I think that use of the endoscope is also worth more discussion because this is an extremely underutilized tool in veterinary medicine. I appreciate how they discuss the complications, especially with the CSF leak. Generally, I'm not able to close the dura either, and we'll cover the defect with porcine small intestinal submucosa, often without being able to suture it to the meninges, because again, I'm doing this for extraaxial tumors, so the meninges are typically lost when we're removing a tumor such as that. For CSF leak, I've only treated them medically with success in each case that I know of. Overall, it was a good paper, and I always get excited to see 3D printing utilized in veterinary neurology, but that's all I have.